For folks who are joining the Huddle for the first time, I want to introduce myself. My name is Anoop. I'm one of the cardiologists at CARE. My co-host for the session, Praneeth, who is also logged in. He is my colleague at CARE as well. And the idea of this Huddle was literally to transfer some of the casual discussion that we have on the hallway or in doctor's office. Hey, what would you do for that patient? What is your thought process? Just bring that casual session on a platform and just have same kind of discussion. We do want to talk science, but we are more interested in seeing how we can apply that science to the practical scenario, to the patient, literally just translating the evidence to clinical practice. Particularly understanding our limitations and truly speaking the real scenario, what happens with the patient in front of you rather than what is the correct answer, because many of the times what we do in clinical practice is not necessarily the textbook answer, but we still do it because we believe for whatever our own weird reason that that is the correct thing to do. And the Huddle really wants to know that weird reason. We just want to understand what is the thought process. And in doing so, we'll pick your brain a little bit, we'll understand how things are going, learn a few, and maybe see how our practice grows along with it. So this is an open session for anybody. So anyone who has a thought, they can unmute themselves. Obviously, just wait for other person to stop speaking and share your thought, or you can raise your hand and I will unmute you to get your thoughts. Really, this is not an expert and an audience model. This is literally where I'm asking each one of the audience about what you typically do in your practice and your thought process behind it, because we want to learn your thought process. That is the consistent theme of this session. So science is welcome, but your thought process is the most important thing in a session like this. So we have two guests here whom I personally invited, and then we have got some new faces as well. So I would invite Dr. Ravinder Reddy. For people who are at CARE, he's a pretty well-known figure. He's a general surgeon and with a very keen interest and expertise in nutrition. So we'll have his thought. We have Dr. Radha here. She is a chief of clinical nutrition at Sunshine Hospital, Sikandrabad, I believe. So we will pick her brain as well in terms of what she thinks. And few names I cannot. I think they are joining us for the first time. So whenever you unmute yourself to share your thought, we would really love to know who you are. So take a few seconds to introduce yourself. We have Dr. Raghu in the audience. He's a senior cardiologist at CARE with us. We have few residents. We have Dr. Vrinda, who is an endocrinologist at CARE as well. So that's the kind of audience we have. And it's about 4 minutes. I typically start the session asking Praneeth a clinical scenario, and then I go around asking other people what their thought is for this particular patient. So, Praneeth, you are ready for my question?
Yes, Anoop. Very good evening, everyone.
Okay. So, Praneeth, we all know the topic of the session. So typically you have patients come into your OPD, young guys who recently somebody checked their blood pressure. Their blood pressure is a little bit on the higher side. So they get all panicky and then they come to a cardiologist that they want to get their life straight. They want to do everything correct so that they reduce their risk of future cardiovascular diseases or whatnot. So this is a 34-year-old IT professional. He comes to your OPD. He does not have any active medical problem. He actually visited his father's cardiologist because his father recently had an MI. And his father's cardiologist checked his blood pressure, son's blood pressure, and that was a little bit elevated. So that got this guy freaked out. So he gets all this package investigation and whatnot, finds that his triglyceride are a little bit elevated, LDL is a little bit elevated, everything else is okay. He's otherwise asymptomatic. So he comes to you to know about every good thing that he can do in his life. And one of the questions that he asks is, I want to eat the best oil that you would recommend for my cooking purposes. He, of course, he consumes Indian food, typically what we do. So the question for you is, Praneeth, with this kind of clinical setup, what is the best oil that you can advise to this patient based upon your clinical experience and knowledge that you think will reduce his future chance of cardiovascular disease? Over to you, Praneeth.
Yeah. So good evening, everyone. Typical case scenario which you see in OPD practice, and this is one of the toughest questions I have to answer, and it definitely is a very uncomfortable question for me when someone talks about diet and nutrition, because this is some area which I'm not totally comfortable. But just to end the conversation, I do suggest them to uh, take any plant-based vegetable oil. So few things which, at least with my knowledge, again, there are experts here which can correct me. What I could know is something which can be kind of is in a solid form, something which can solidify, is high in saturated fat, something like ghee, coconut oil, or something like this, that dalda, vanaspati. So you avoid them, butter probably as well. And something which is flowing is good in unsaturated fatty acids, which are kind of healthy. And most of the plant-based or vegetable oils are healthy. So preferable things being olive oil, in my opinion, is one of the best, but it is because expensive, people don't use it frequently. The next best option is sunflower oil. Many brands are there. Again, I really don't know how best it is and all. So the other thing which I know, or I at least are familiar, is something called rice bran oil, which I really don't know how it is a makes a difference. And somewhere which I know or I heard is that you keep changing the oil pattern so that you can get benefits out of most of it. So I politely tell the same thing, that you better consult a dietitian or nutritionist. But this is what I suggest: is any plant-based oil, avoid those solidifying oils like ghee, vanaspati, dalta. Use some vegetable oils, preferably sunflower oil, and if you can, try to change like once in a month. If you use sunflower, then you try to use rice bran or something like that. So say, and that is how I can end the conversation.
Okay, so basically, I don't think I've ever heard a cardiologist sound so confused previously. And I think this question does confuse a lot of cardiologists. So, Dr. Ravinder and Dr. Radha, I'll get back to you because I think that once you speak your expertise, then I think a lot of our thoughts will change in the real time. So, I'll get back to you guys. I want to have Dr. Raghu weigh in. Dr. Raghu, what is your preferred, what is your favorite oil that you prescribe to your patients or use yourself for that matter?
Okay, mostly I agree with Dr. Praneeth, but over the years I've been reading a bit on these oils, and what I tell them is it really doesn't matter. I mean, there are no studies which have shown that olive is the best and sunflower oil is the least, or groundnut oil is the least. I mean, it's impossible to do a random trial on these things, because nobody can stick to a particular pattern. Unlike drugs, nobody can stick to a particular pattern and eat the same thing over and over again for years together to show that the natural history is better with a particular oil. So we go by broad diet things like the amount of saturated fat should not be more than 5% in any oil. And there's this thing called trans fat, which should not be there in an oil. And so any, like Praneeth said, any oil that is always in liquid form at room temperature is basically good. Now, I was talking to my niece just a while ago. She is fairly high up in in Marico. It's one of the fast consumer good products company in our country which sells what is called Saffola Total and Saffola Gold. Now she said this is a mixture of sunflower and rice bran oil or curry seeds with rice bran. Now they project that Saffola Total is far superior. So I asked her, what is it that you base your thing on? Have you done any? She was very vague. She said, okay, we've done some, there's a lot of backup to what we are projecting. I said, tell me honestly, is it not a lot of hype? And very quietly, she said, there might be a little bit of hype also. And she being an MBA, I don't trust MBAs at all. I know that their concept in life is to sell anything. They are capable of selling stones as good nutrients also. So I don't trust them basically. I've got this deep-rooted dislike for MBAs. So coming back to the subject of oil, so I just keep it plain and simple to the patient. I tell them that whatever form of liquid oil is available in our country is fairly good for use. It is possibly wise to rotate it every month. For example, if you have used rice bran oil this month, you can use sunflower oil so that you're exposed to all the good aspects of the various oil. But the best thing is not what oil you're using, but how little you're using. And of course, a few things like the basic problem of oils in usage in our country is the fact that we tend to heat them to very high temperatures and you reuse them. Now, whatever benefit you might have, even in olive oil or in sunflower oil or Saffola oil, by reheating, you're destroying the properties of the oil and you're inducing a certain amount of hydrogenation in the oils, and thereby you're endangering yourself. And also, there are other things which point towards the fact that reheated oil consumed frequently can lead to carcinogenicity and all that. Of course, how much of it is proved, I do not know. This is all anecdotal hearsay, what you read in the lay press. I am not aware of any study which has specifically looked at each one of these aspects. And like I said in the beginning, any study on these things can be very, very difficult to prove. So we just go by common sense. We decide of which oil has how much of saturated fats. Of course, many of the oils come with their own label saying zero cholesterol, zero trans fats and all that. Of course, you take it with a pinch of salt, but even if it is not zero, if it is at a very low level, then you are fairly safe. I think I'll conclude. I've taken a bit of your time, Anoop. Thanks a lot.
Thank you so much, sir. I hope Dr. Ravinder and Dr. Radha are taking notes because there are a lot of questions that will be coming to both of you guys. Anybody else, other than my two guests, anybody else has any other thoughts to add before we start asking specific questions? Please speak up your mind, anything that you think in terms of your practice patterns. What do you do? Anybody in the audience who would like to weigh in? Okay, so that looks like I'm not the only one who is confused. All of us are. So, Dr. Ravinder Reddy, tell us, get us out of this misery.
Thanks a lot, Anoop. Thanks a lot, Anoop, for inviting me. Even though I'm not a trained dietitian or a nutritionist, in fact, my familiarity with the science of nutrition stems from the fact that when my wife was doing MSc nutrition, I was doing my MS and I was reading more of her books rather than my surgical books. And that was the baseline. And then subsequently, when I was doing my postdoctoral fellowship in critical care at Hammersmith Hospital, that's where I really went on to the clinical nutrition. So my familiarity, or perhaps even I dare enough to say that my expertise lies in clinical nutrition rather than dietetics, which is basically, that's why I requested Dr. Radha to join us so that we can actually share the opinion. Now, coming to both the Praneeth as well as Dr. Raghu sir, they were spot on. Of course, all of us are confused. In fact, if you look at the biochemistry of oils or fats, that is the most confusing one. Because you have long chain, you have short chain, you have medium chain, you have MCTs. There are so many. You have the saturated fats, you have unsaturated fats, many, many things, enough to actually cause many a confusion. Having said that, oils are fats at liquids, liquids at room temperature, which Pranit said is very good, and even Dr. Raghu reiterated that, and it's very nice that they got it spot on. However, any fat can be good, any fat can be bad. It depends on the company it keeps. In fact, if olive oil, which is purported as, there are quite a few studies actually, contrary to what Dr. Raghu said, there are quite a few, most of the studies which I am aware of have been done at Tufts University Hospital, the Nutrition and Cardiometabolic Center from Boston. So there have been quite a few studies that actually have shown that oils can be, all oils, they increase the satiety, they increase the taste. Having said that, 1 tablespoon of oil is about 90 calories. So if somebody takes olive oil on its own, saying that it is unprocessed or an extra virgin olive oil, he or she will put on weight, and it will not be good as far as their cardiovascular system is concerned. However, if they have the same olive oil, extra virgin olive oil, which is unrefined, and have it along with a Mediterranean diet, or in other words, a lot of vegetables. So the company which it keeps is actually, then it turns out that on the contrary, the weight loss actually reduces and there is increased amount of positive clinical effects. I'll not go much into that. Now, talking about reheated oil, yes, there have been studies to show that once you heat, especially it's called smoke point, there are quite a few oils which are not stable. So at smoke point, there's a thing called lipid peroxidation. Now, all of us know that fats are quite a significant number of them are unsaturated. That means they have these hydrogen bonds. They are very loosely, they have loose links. So when it is heated, it's called as lipid peroxidation. That actually causes, as Dr. Raghu said, it lands up in increased incidence of polymerization, which actually goes and increases the LDL. Some oils actually increase the HDL as well, but more important is they increase the LDL. And not to forget that they can actually provoke the production of secondary bile acids and thereby causing increased cancer. So before I go on to the specific oils, which are good, which are bad, all oils are actually good or bad as long as we have not more than 15 ml, not more than 15 ml in 24 hours. Ideally, it is given the Indian way of cooking, it's better to avoid reusing the oil which has once been heated for frying or whatever. And also, if you are having oil, we see that we limit the amount to less than about 1 tablespoon, that is 15 ml in 24 hours. I'll take on more questions, but I'll present it back to you, Anoop.
Thank you so much, sir. Before I get to Dr. Radha, anybody has any follow-up thoughts, questions, or anything about it? So one of the questions which is being asked is, what is this virgin or extra virgin in olive oil? And since nobody else is speaking, let me get to Dr. Radha. Dr. Radha, I think that you have a lot to unpack here. Let me start with this question first, which the audience asked. What is this extra virgin in olive oil? And tell us what we should answer to that 34-year-old guy whose father had an MI at the age of 55. What oil he should take so that his blood pressure is better and his cardiovascular risk is low. Dr. Radha, on to you.
Thank you so much for this opportunity that I could interact with all of you all. I hope you all can hear me.
I can hear you.
Yeah. So first, coming to this question of answering the young guy who's come with a history, and how do we as dietitians handle is, first and foremost, as the other two earlier interactions also said the same thing, we first tell them to control. In fact, we take a detailed diet consumption history. First thing is, we ask them about how much oil are they consuming. If they say we don't know, then we ask approximately how much oil they are using per month and how many members in the house, and we calculate it down to what they probably would be consuming. And then we tell them this is the amount that you are using. And what you can actually do is, as Dr. Reddy said, and even Dr. Raghu said, that it is 15 ml, 3 teaspoons of oil per day, which boils down to 450 ml per month, or half a liter. One packet is 900 ml, so half for one person is what we clearly explain. But the person is really intelligent. They come back to us and say, fat, we can take up to 30% of the total calories. Then I go back and tell them that visible fat, fat, whether you take it as ghee, whether you take it as oil, whether you take it as butter, should be 3 teaspoons per day. And the rest comes from invisible, which is a part of the food which you cannot assess. So you have to really be controlling this. This is point one, which we make it very, very clear to them. There are some Marwadi families who come to us and say, we cannot stay without ghee. Then I tell them, yes, you go ahead, because I cannot say no. I do tell them, yes, go ahead, use ghee, but see that you reduce the oil. But the total intake should be 3 teaspoons per day. That is point number one that we generally explain from patient point of view. And then we tell them, you keep changing the oils because each one of them has different compositions. As the first speaker, Dr. Praneeth, did say that about olive oil. Yes, olive oil is an Indian substitute, or the Indian substitute for olive oil can be rice bran oil, because the MUFA content is almost nearing to olive oil. Exactly not, but it has a larger content of MUFA. So we do tell them that you change oils, do have polyunsaturated or monounsaturated fatty acids. These compositions have to be there. And then coming to the technical part, we do explain to them that there are studies which say that if some come back to us and ask, can we take coconut oil? Because nowadays the hype is that we are taking coconut oil. Is it good? Not good. But then coconut oil also has the bad part of it, that is saturated fat. And there are studies which have proven that 1% increase in intake of saturated fat increases the LDL by 3%, 2 to 3%. So this is what we tell them. See, your LDL can reduce with saturated fat reduction, but this is what does the study say. So you decide whether you want to take ghee or oil. That is another thing that we tell them. And it is not necessary that people will stay healthy if they take olive oil. No. The quantity is more important. Whatever oil you take, the quantity is more important. And another thing is, how are these saturated fats substituted? That is more important. If saturated fats are substituted by trans fats, then what happens is the risk increases by 5%. If the saturated fats are substituted by MUFA, that is like olive oil or rice bran oil, then the risk reduces by 15%. If it is substituted by PUFA oils, then it is reduced by 25%. If it is substituted, or the saturated fat is substituted by intake of more refined carbohydrates, which finally gets converted inside the body, the risk is increased by 1%. And if the saturated fats are substituted by carbohydrates from whole grains, then the risk reduces by 9%. So these are things that we have to keep in mind and tell them that you just don't reduce your oil, you just don't change your oil, but your overall diet pattern has to change. It's not just about oil. Oil singularly does not work inside the body. It's the whole lot which works. So that is something that in counseling that we have to give them little of evidence, little of counseling, and then fit it into what they are actually taking presently. That is to your first question. And then coming to your second question about what this virgin oil and extra virgin oil is. See, it's a processing method, and it's a very hyped up name that it's given. Virgin oil is something where they don't, it's called as cold press oils, where they don't use any chemicals, where they don't use any heat. It's basically that. So they believe that the antioxidants of the oil are intact when you actually have them as virgin or extra virgin oil. So that could be a better health outcome, along with using an olive oil which is high mofa content, and so it could be a double health benefit. But the health benefit comes provided we maintain the quantity. And there have been a number of studies, especially by Dr. Ghafurinisa Begum from NIN, long time ago, who's done a lot of studies on fats and oils and cardiovascular disease in the Indian setup. She has proven that changing oils is a better benefit than sticking on to one kind of oil. So this is another thing. Have a combination, but the whole thing should be coming down to 15 ml per day. I think this is what, as a dietitian, I can say practically. Anybody has questions, I can still answer.
Okay, ma'am, I have a quick follow-up question, and then I will ask the rest of the audience. Sorry, there is some noise there. I'm muting everybody. There's some noise there. Okay, ma'am, question is, you briefly touched upon this cold press and virgin oil. So my direct question to you is, rice bran oil, refined versus cold press, better, worse, doesn't matter?
Yeah, it does. See, cold press is better quality, yes, but the affordability is something that you have to see. Especially in the Indian scenario, I do not advise for everybody. Maybe it is one patient in a month whom, who's really hyped up, and I say, yes, go ahead, use the cold press oils. But 90% of my patients, or 99 patients of mine, 100 patients in a month, I say go ahead and use rice bran oil, because that is something that is easily available. If they are able to afford and they know the benefit, then yes, cold pressed is really good. But this is an advice that I generally don't give.
Dr.
Generally
Ravinder
don't
Reddy,
give.
some
And
comment?
most oils, and let me tell you,
Yeah.
most oils in India
Sorry, sir.
are, sorry,
Dr. Ravinder,
I
let
can't.
Dr. Radha finish. I thought she was done.
Yeah. No,
Yes, ma'am, go
and
ahead. Ma'am, go ahead, please.
most oils, the vegetable oils in India are added with extra quantity of vitamin E. So, the antioxidants are fortified. So I think there is some benefit if you can use the regular vegetable oils. I think sir also can add on.
Dr. Ravinder Reddy, you had some comment?
Yeah, the only thing is, this is regarding the virgin and extra virgin. The extra virgin is, when my patients ask me this, I actually tell them, have you seen any, the sugarcane juice wala? The first time he puts the huge sugarcane juice and extracts the juice, that is the extra virgin. And he uses the same thing again to extract some more, that is the virgin. The same thing is with the olive oil. Extra virgin oil is the first press, which has got the highest polyphenols and antioxidants. Whereas the same thing again is reutilized or pressed again, and it becomes, the amount is still there, but significantly less. In the market, in the supermarkets, you'll find olive oil without the label extra virgin or virgin. They are no different from any other oils which are available. The other thing which I wanted to tell you all is, like Dr. Radha said, most of these are calorie dense. In fact, they contain more calories than even butter. Butter actually, which has about 16% of butter, is water, whereas the entire 100% of oil is actually fat without the presence of any water, because the water does not dissolve in them. But I've seen some questions coming up, but we'll go on further as we get down. The other thing is, as Dr. Radha said, the reason why it is costly. Extra virgin olive oil in India is very costly. Very few of us Indians can actually afford it. But it might surprise some of us that it is the most duplicated food on planet Earth is the extra virgin oil. So we have to be very, very careful whether we are getting any fake oils or whether it's really one. The second one, if anyone's interested, is actually the Hanukkah honey. but the most duplicated one food in the entire world is actually the extra virgin oil. Anoop.
Before you leave, before you finish this sentence, I have a follow-up question on that. So Dr. Radha is mentioning to reduce the oil content. If we reduce all the fat, how will we get fat-soluble vitamins? Don't you think we'll become deficient in vitamin A, D, E, K if we reduce the fat content that much? Dr. Ravinder, question for you.
No, we don't need to. We don't need to. We need 15 grams is sufficient. 15 ml is sufficient for us. Only thing is, if somebody has only, let's say, extra virgin oil, that is MUFA, the limitation is not because of the absorption of fat-soluble vitamins, but because of the lack of essential fatty acids in the pure MUFA oil, that is pure extra virgin oil. That's why we have to have a combination. One of the common combinations I've advised from the Tufts University is actually have olive oil for salads and for light cooking, that is something on your chapatis or whatever. And you can have coconut oil to a certain extent for high temperature Indian cooking, but we at home, we use canola because it has got a very high smoking point of nearly 250 degrees centigrade. Canola is very good. And it's got a neutral flavor and very high amount of PUFA. So we get adequate amount of essential fatty acids from them. Now, coming to fat-soluble vitamins, the reason it's called fat-soluble is we don't need basic oil for them to absorb. Any amount of fats in the diet, let it be 5%, 10%, or not more than 15%, that will stimulate the production of the pancreatic lipase. The pancreatic lipase is the one that actually converts the macronutrients in the form of fats into smaller molecules. Triglycerides are broken down into fatty acids, and from there further on into micelles, and that's how they are absorbed. Whereas the medium chain triglycerides do not need pancreatic lipase. They are directly absorbed from the intestine into the portal radicals. But most of the fat-soluble vitamins are co-absorbed because they're soluble in fats along with pancreatic lipase. So having 15 ml, that is adequate. Remember, one spoon is actually 90 kilocalories. So we are getting at least about 90 kilocalories or minimum from fat. That is more than enough, spread out over 24 hours. That is more than enough to actually see that we have adequate homeostasis, adequate digestion, adequate absorption as far as vitamins which are soluble in fat are concerned. And if we rotate the oils rather than sticking on to one oil, as Dr. Radha said, rotate the oils, then we also get the essential fatty acids. Whereas if we stick to only one oil, like olive oil, we will not be getting the essential fatty acids. Anoop?
I have two more direct clinical question. It could be a one-sentence answer. MUFA versus PUFA, which one is better, in your opinion?
Both. The duration, the amount is important because excessive PUFA, for example, I'll give you, we are in the midst of COVID. Suppose somebody who's in the midst of throes of the cytokine storm, and if his diet is purely or excessively PUFA, it is pro-inflammatory. So somebody who has excessive PUFA, that is omega-6 especially, they are pro-inflammatory. That's why we need to have a balance of omega-9, omega-6, and omega-3 fatty acids. I just saw somebody asking a few questions. The question on what should there be a ratio? Yes, there should be a ratio of omega-3, 6, and 9. At least 1/3 of the amount should be from the omega-6 and also the omega-3 because both of these contain or contribute to the essential fatty acids. So MUFA, majority of the MUFA is good. Most of the nuts which we eat are very rich in MUFA. They are good, heart healthy. They will not raise, they increase the HDL to a certain extent. Definitely, they will not raise the LDL, whereas PUFA can raise both LDL as well as HDL, just like saturated fats. Nope.
Perfect. Thank you so much. And we'll let you pause for a few minutes. Maybe you can catch your breath.
Yeah.
We'll open it for the audience. Anybody who has got any thoughts. Dr. Shastri joined, Dr. Chandramukhi joined. They both are senior cardiologists at CARE. Dr. Raghu, you have something comment, and then I'll get back to Dr. Shastri. Dr. Raghu, please go ahead.
Years, I mean, a few decades at least, I've been insisting that we do not use more than half a liter per head, per each family member. And it works out to approximately the same thing that has been stated by Dr. Radha and Dr. Ravinder. Now, the problem is the normal cooking process in most vegetarian homes is not much of usage of oil. But then everyone occasionally does enjoy a deep fried stuff. For example, I cannot live without my weekly Sunday breakfast of puris. So puris are deep fried and you get a lot of oil in. So basically, if you can control the level of oil intake during your normal cooking, then you have the discussion of using some tasteful food items now and then, so that you don't become a person who feels that there's no point in living altogether. So this is something very important. When you talk to a patient, say, okay, reduce this, reduce that. I have had quite a few people come back and say, look, I don't feel as if I'm enjoying my life anymore. This is after an MI. I tell them, you cut down on your non-vegetarian, you cut down on your oil. And the patient comes back and says, after a couple of weeks or 2 weeks, after the initial fear of an MI has receded, he says, what am I living for? So you tell them, okay, you be as logical about it as possible. Try to give yourself a little leeway once a week or once a fortnight. But most of the times, if you can adhere to the norms that have been stated, then you should do well.
Thank you so much, sir. Dr. Shastri is here with us. My next question, I'll just ask Dr. Shastri's opinion. Sir, we are talking about this clinical scenario where there is a 34-year-old guy whose father got diagnosed with coronary heart disease at the age of 55. Now this 34-year-old gentleman, he is getting super excited about what he can do to change his lifestyle so that he can reduce his risk. And the discussion is on oil in terms of how we can change or modify or advise him so that he can reduce. So my question to you is two. One is, what would you advise this guy, 34-year-old, of oil uses, so that cooking oil we are talking about, so that his cardiovascular risk is reduced? And as a cardiologist, a 55-year-old guy comes in with post-MI. Is selection of oil important for secondary prevention at that age, or you think that that boat is already sailed and now it really doesn't matter which oil you use? Dr. Shastri, your comment, please.
Well, I am not sure. I really honestly, I don't know. The purpose of joining the meeting is to learn from all learned people, especially Ravinder Reddy. I'm so excited to listen to him, though it is only last few sentences. Personally, I have no idea. I am so confused about it. There's a time when I used to read more about these things, but now I don't know how much to believe, how much it's really effective. I really don't know whether the oils really matter or do not matter. All these the primary and secondary prevention things, they work for groups, not for individuals. If you take a group cohort of people and implement any of these methods, including control of hyperlipidemia or hypertension, etc., that seems effective. But when it comes to individual patients, the genomics matter, gut microbiome matters, and simply weight matters. I can't say more. I don't know. Thank you.
Thank you so much, sir. I think I'll just comment for a minute. So one thing that I did notice amongst everybody talking, that while we are talking about cooking oil, when we discuss with the patient, we have to look at a comprehensive approach in terms of what Dr. Ravinder Reddy said, that the company it keeps, or what Dr. Radha said, the amount matters, or Dr. Raghu said the rotation matters, or Dr. Praneeth said the saturated versus unsaturated. And then the very important point that Dr. Shastri and Dr. Raghu brought was that the psychological effects of what happens when you do a completely restricted diet, because that also has got a cardiovascular bearing. So maybe we are reducing some risk by this dietary modification, but then we are increasing the risk because of that psychological stress or whatnot associated. Unhappy mind is an unhappy heart, truly speaking. And then what Dr. Shastri said, that we have to look at a holistic picture where something may work in cohort but may not work at an individual level. So these things we are making a decision in the clinic. We certainly can apply that as a cohort in our patient as well, in terms of it may not work for that particular patient. But if we have a tailored advice for, let's say, 100 patient, we may be able to apply that cohort dynamics to that as well. I will ask the same clinical question to Dr. Chandramukhi as well. Ma'am, what would you suggest to that 34-year-old guy, and what would you suggest to that 55-year-old person, with one who did not have any event and the other one who is just recovering from acute MI, in terms of dietary modification of cooking oil? Do you have a favorite? If you do, please explain.
Uh, I also don't have much experience with primary prevention and secondary prevention, but definitely if this 34-year-old guy is having a risk factor like family history of coronary artery disease, so I would like to recommend the dietary restrictions with reduced quantity of oil, and as everybody mentioned that rotating oils will be a better option for using healthy oil. So this will be my advice for both father and son.
So much, ma'am. Do I have Dr. Johan here? He joined. I don't know if he's there or not. Dr. Johan, if you are there, would you weigh in? I think he left. Okay, let me get to a few questions. Dr. Radha, I have a question for you. And this is something which I cannot put my head onto. So you go to European countries or you look at European data, they will swear by saying how good olive oil is. You go to America, they would all talk about corn oil or peanut oil, although olive oil is famous there as well. You come to India, the southern part, Kerala and all this, they would swear by coconut oil. We have been using in our family for centuries. We all are pretty good. You go to the Hindi speaking belt, UP, Bihar, northern part of India, they would swear by mustard oil. You go to Gujarat, Madhya Pradesh kind of places, they will swear by groundnut, peanut oil, those kind of things. A lot of it is regional. I think there is regional favoritism. Because if people in Kerala all of a sudden find that mustard oil is good, God knows how they are going to get it. And the same thing will happen with the northern part of India. If they start realizing that coconut oil is better, God bless. So how is this regional difference going on? There are people who take mustard oil for a long period of time. There are people who are taking coconut oil. I know when I initially joined CARE, some of our advisors, they would actually recommend post-MI patient to categorically consume 2 teaspoons of coconut oil every day on the top of their cooking. Because of that firm belief that coconut oil will increase HDL. By the way, there is a lot of clinical data that consuming coconut oil does increase HDL, and that has been shown in multiple trials. But that method of raising HDL has never been shown to improve cardiovascular outcome. In fact, the data goes the other way. The clinical outcome data suggests that consumption of coconut oil could be detrimental rather than helping in spite of HDL increase. So, Dr. Radha, can you just weigh on this in terms of what is this regional difference? Is our genetics different? The way gut biotome is different? Is something different that Kerala people find it better to consume coconut oil and Bihar people find better to consume mustard oil? Dr. Radha, to you. I have to unmute you. Give me 1 second. Give me 1 second. You are muted right now. Yes, ma'am. Please go ahead now.
Yeah, this is actually generations of a habit that has developed, and so the genetic makeup also, the microbiome also has adjusted to this usage of oil. So you cannot, and they are used primarily, all of us want each kind of food, or we prefer to take for the taste factor. So from when you are a child in Kerala, you are trained to take coconut oil. So physically, your acceptance to coconut oil is very high, and added your body responds to it because your genes are also tuned to it over the years. So the risk factor that we talk about having high amounts of coconut oil could be higher in non-Keralites than those who have been using coconut oil for generations. So same thing with mustard oil. Some of us cannot bear the taste of mustard oil in food, but there are regions where everyday cooking is done in mustard oil. So that's a taste factor which they generally get acquainted to. That is the only answer that I think is the best way, and so it becomes regional. Like if you see, we add in Andhra, we add only till oil for making pickles because the taste is heightened and it's a different taste when you add sesame oil to pickles. So it's that which is, our cultural background tunes us to using those oils regionally. Yeah.
Dr. Reddy, yes, ma'am. Reddy, I have a question for you. I want to mute you for a second. There's a lot of noise. So the question here is, you said you use canola oil occasionally for your cooking and whatnot. Canola, which is, sorry, Dr. Ravinder, I'm going to unmute you. There's a lot of noise. I'm going to mute you, sorry. So the rapeseed oil, which is canola oil and mustard oil, they both are kind of, if I'm not mistaken, either in the same family or very close by. And mustard oil, as somebody pointed out in the comment section, is banned in US for human consumption. And canola oil, which is equally high in so-called erucic acid, the reason why mustard oil is banned. The whole data comes back from 1970s animal model, where they showed that high erucic acid content is detrimental to heart, to the tune of could be being directly cardiotoxic, but never been proven in human studies. In fact, never been done in human studies that categorically. But animal study do show that. And then canola oil potentially can have similar kind of erucic acid. So how come canola oil is famous in US and Europe, Canada particularly, versus mustard oil is not? Is there some racism there? What is going on? Dr. Ravinder Reddy, question for you.
Thanks a lot. Just a few points of clarification. Regarding canola, it's pressed from the seeds of canola plant, which in a way is a member of the mustard family. Although, like you said, it is related to the rapeseed oil, it is not the same plant, by the way. It is entirely different. And the smoke point is quite high. It's about 468, that is nearly about 250 degrees C. It can be used for stir frying, which is very common in India, or salting, including salads, or even for baking. And it's got a fantastic flavor. It's got the lowest saturated fat content of all the commonly available oils. And some of them even supply the plant-based omega-3 fatty acids. So, and the plus point of these is that it can be used for the Indian style of cooking. Now, the research the publications which you mentioned are pretty old, and there have been some new ones, especially in the late 90s and in the mid 2000 up to 2005. Quite a few studies on different oils. This was actually in cardiovascular cohort. This was a prospective open label versus prospective placebo. I mean, they knew that they were not getting hence it was an open labeled one. And they did find that, yes, the LDL certainly reduced. My point, I just picked up the point which you said that coconut oil actually raises the HDL. Now, more than 70%, up to even 90%, according to some papers of coconut oil, is actually saturated fat. And there have been very good studies to show that it increases the LDL. And the American Heart Association categorically states that coconut oil is dangerous as far as heart health is concerned. Is there anything else, Anoop?
That's pretty much it. Let me just open it to the audience. Maybe we'll get some questions there. If not, then I'll put my thoughts again. Anybody in the audience who has got any thoughts, any of their practice patterns or any questions for Dr. Ravinder or Dr. Shastri?
Yeah, I mean, this I'm not so authentic as Dr. Reddy, but I'll share few points which I learned over a period of time. Now, coming to the coconut oil, yes, actually, couple of years ago, almost it's couple of years now, Dr. P.V. Satyanarayana was advocating this earlier. He came, he gave talks and all. Then we wanted to prove it. There's no point going by uncontrolled trials. Actually, we wrote a protocol, we took ethics committee permission, and unfortunately, we could not do it. So at that time, I went through the coconut oil literature, and nearly 25 to 30 studies are there. Most of these coconut oil studies are small studies, short-term studies. They did not particularly look at the outcomes, and the benefits are neutral or not inferior to other oils, depending on the investigator bias. So the hard data is not there for so-called coconut oil therapy. Now, it definitely increases the LDL cholesterol. Now, increase in HDL cholesterol, we should know that you increase the fat consumption, HDL also goes up. If you totally restrict the fat consumption, HDL comes down. This is one of the typical problems. Of late, we are not giving so much importance to HDL, which is increased by any pharmacological or dietary means. And it is a marker for decreased or less atherosclerosis, but it is not, we do not know how the cause and effect relationship is there. So what I mean to say, by increasing HDL cholesterol, we have not demonstrated hard clinical outcome data in large studies. Actually, pharmacological studies, it has been harmful. So nowadays we don't bother so much about HDL. Now LDL is definitely has always been there, and coconut oil definitely increases LDL cholesterol. I have seen quite a few patients, because for some time I used to advise my patients to take coconut oil, but closely monitoring, and most of them have increase in LDL cholesterol. Now, the another point which I want to make is looking at the anecdotal experiences. Of course, anecdotes won't make science, but some things which bother me. At least 5-6 patients of mine who have got very diffuse, deadly-looking coronary arteries. There's hardly any blood flowing. Not very old, middle-aged people, and I asked them what they eat. Instantly, all of them said they eat beef every day. Sometimes it makes me think whether the Indian or Hindu custom of not eating beef, was it because millennia ago they realized that beef eating is not good for the South Asian ethnic groups? I do not know. It is just, it always goes in my mind. The second thing is, having said that, one of my classmates I know, who has been, that pure vegetarian, that Siddhi Samaj Yoga fellow, he's a pediatrician. His coronary arteries are as bad as these people who eat beef. So I really do not know. And I just wanted to know from others, what is the role of this ghee? I don't know. People who eat a lot of ghee, I don't think they are particularly vulnerable for aggressive coronary artery disease. Quite a few of my, the people I know, they take a lot of ghee, and their carotid arteries and general health is absolutely all right. No evidence of any atherosclerotic vascular disease. So I thought I'll just share these ideas of mine. Thank you.
Thank you so much, sir. Dr. Ravinder, could you answer this ghee conundrum? And then I'll go to Dr. Radha for the other questions.
Yeah, ghee in moderation again is good. Maybe about not more than 2 or 3 or 4 ml per day. But remember, ghee is clarified butter. Only the so-called Indian dietitians, I mean, Radha apart, which we see on the social media, they say that ghee is very good for heart health and other things. But if you go and actually look at the prospective studies on clarified butter, which is ghee, then the numbers actually don't add up. In other words, frequent or daily consumption of clarified butter may not be that good. But again, occasionally is okay, or in smudget amount, maybe less than 2, 3, 4 ml or 5 ml per day. I know at least a cardiologist who actually has about 2 or 3 ml per meal of his. And and one of the best things is it increases satiety. But if somebody indulges or goes overboard with ghee-rich foods, and I'm sure they are the ones who are asking for trouble. With that, let's see what Dr. Radha has to add on to this ghee conundrum.
Radha, your comments on ghee, please. And let me unmute you. Okay.
Yeah, this is again a cultural practice that we have, that once the child is introduced to food, it's best introduced with ghee. That is a practice, so it keeps going on, and it's believed in general population that ghee is more healthier than oil or the regular cooking oil. So they get into this habit of giving ghee for every occasion within the family. But ghee, I'm telling you, in my practice, if the patient or the attender wants to give ghee, I say yes, because I cannot go against any cultural norm while I'm giving the dietary counseling. But I tell them, you be within this. But a person, as somebody who has a risk, comes back asking for ghee, whether they can take, then I tell them that you already have a risk, and possibly that it's better you avoid ghee than using, because it is more amount of saturated fat. It's just that. But once in a while, once a week, I tell him, if you've not taken it for 6 days, the 7th day you can take a teaspoon of ghee. That is what I generally advise as a dietitian to the patient. And yes, it's just a cultural norm.
Follow-up question on that to you. So in the Mediterranean diet, when we looked at the data originally published in EJM, all this big havoc that Mediterranean diet is good and all this, when they looked at the fat content of these diets, including olive oil, they considered low-fat diet as 40% fat consumption, 40% of the recommended dietary allowance per day, which for a lot of American diets were also not a low fat content. They were actually 40% would, by any dietetic measure, would be considered a high fat content, if anything. And now we are talking about here to reduce the total fat content either with oil, and of course the invisible fat we can't see. So if we reduce the oil, that has to be supplemented by something else. And the most common thing which is supplemented is simple carbohydrate or refined carbohydrate. So if you have to choose as a dietitian in cardiovascular space, out of the two, which is a bigger enemy, you reduce the oil, but then the carbohydrate takes space. And we know carbohydrates are the newer enemy to us. So how do we handle that part in the current space? Dr. Radha.
Yeah, see, if you have to really see, I have worked with these patients, I have gone in detail of taking their intake, been a part of few of the research studies, public health studies done by NIN, where we looked into the fat composition or the fats and oil composition of their daily diets. And we found that it is never 15 ml visible oil. Even if I advise 15 ml, it will go up to 25 ml. If I say 3 teaspoons, mostly it will go up to 5 teaspoons a day if somebody is really rigid. And this is a part. And if you are looking into the total fatty acid, fat percentage of the total calories, invisible fat, you go into the nutritive value book and look at these foods that we consume, we do come to 20 to 25% of the total calories from fats. So we are not less. We are not less. We are, it's just that on a day-to-day basis, you cannot open the nutritive value book and calculate the fat composition of your total calories that you have consumed. So we assume we are taking less. It's not that. On an average, we are on to 20 to 25% of fat intake on a regular basis. So it's not less. And even if you say you are less, you substitute it with whole grains, whole pulses. It is not just with refined carbohydrates. It's not. You have to make a combination of all foods, convert all these instructions, or let's say guidelines, into a diet, because what the patient wants is the diet plan which he or she can follow, and that is what has to reflect in a diet plan. You have to tell them what is the benefit of having fruits and vegetables, what is the benefit, how much of carbohydrate you will get from them, what is the benefit of eating just idli, or what is the benefit of eating a combination of whole cereal and something like idli made from refined rice. So this is what we make them, how they can include pulse in their day-to-day activity, their intake, how at least 3 times a week they can include pulses as sprouts in their diet. So these are things which we have to inculcate, and happens over a period of time. Overnight you can never see a change, but make a combination.
Ma'am, I have
Yeah.
one more question. We
Yeah.
discussed about trans fat for a moment in terms of it is bad. Can you tell us
Yes.
which oil has got higher trans fat so we all can tell our patients to avoid that part?
It's not higher. See, it's not the higher, which oil has higher trans fats. It's not about oil. It's about the kind of processing that is done to our oil to give you trans fats. So, trans fats, if you take vanaspati, okay, vanaspati, which is used in almost every bakery product, because that is what gives you the crispy feeling of the bakery product, and it's low cost. So that is what is trans fat. So you are going to tell them, we are into so much of biryani that we eat, but 75% to 80% of the biryani oil that contains is vanaspati. Let me not use the brand name, but it is vanaspati. That is what is trans fat. Because that the minute you know that your biryani is sticking to your hand, it has vanaspati. Simple. You just tell your patients. The minute you eat vegetable or non-veg biryani, it is that. You go to a restaurant and you eat. You eat your puffs, you eat your whatever, samosas. Samosa is crispy outside. Why is Amma not making crispy samosas at home? Because there is vanaspati used. That is what is important. So that is what is the danger of eating outside food. I think.
Yes,
Can I
Dr.
ask
Shastri. Yes, Dr. Shastri.
one quick
Yes, please go ahead.
provocative question to you? I take atorvastatin 80 milligrams and ezetimibe 10 milligrams. My LDL cholesterol is 37, repeatedly checked. I consume vegetable salads, sprouts, and fruits almost daily on various combinations. Should I bother about the cooking oil and what oil I eat and how much oil I eat?
Your LDL is not the only marker which will tell you your heart health, sir. It is not the only marker. I hope I'm right when I'm saying this. The others should agree.
You are perfectly right. I have no doubts in that. But
Yes, sir.
typical methods of measuring other things like oxidative stress, we don't measure about the oxidized LDL cholesterol, which is actually very strong risk factor compared to the LDL cholesterol. We don't look at the phospholipids, we don't look at the circulating fatty acids, and there must be many more markers. But in the absence of it, how do we say the one marker we have is LDL cholesterol and triglycerides HDL in routine practice?
Yes, sir. What you can do is you still have to tell them that they have to be on a recommended quantity of oil. And what is most important is a overall balanced approach to the diet. It's not just about oil. Oil doesn't work singly, sir. That is one main thing. I'm always worried about how to bring in this combination and a balanced approach to every meal in the day, whether it is breakfast, whether it is lunch, whether it is dinner. How much of protein, how much of whole grains, and how much of oil goes into breakfast? How much does it go into lunch? visible, invisible fat, protein, and carbs. And then how much goes into the dinner? This is what is important. It is that which creates a positive gut microbiome. And that is what is going to bring about the overall health outcome on a long run. One day doesn't work, sir. One day, 1 month, 1 year doesn't work. It is over the years that it works. Eating 5 servings of vegetables and fruits every day is a norm that I have been reading for 20 years. And you have to follow it. Eating 5 servings, that is half a kg of fruits at least, every day makes a difference. My younger children are 21. My elder one is 25. For 20 years, I've been doing this, sir. Not a day I have missed. That makes a difference. That is what is your strength, and that is what will matter even if you take little more oil. So it's not just about oil per se. It is the overall approach that you give. And what is more important is your exercise pattern. Let it be just moderate exercise, but how active are you throughout the day? That matters. So all these, as a dietitian, I have to educate my patient. Spend time. My counseling time is 1 hour per patient. They come on appointment to me. I just don't take in walk-ins, sir. I convince them to come back and tell them how long I take. And every meal is explained to them. It is not a printed paper, sir. Just collecting their food details of their regular intake takes 20 to 25 minutes for me. And then I make out a plan of what they generally eat. Not what I want to give, what they are eating. Within that, we make a plan and make it more healthy and give it to them. That is what is important. I don't know whether I'm really convincing, but this is what works.
Thank you so much, Dr. Radha, for those comments. I will quickly go over and read some of the comments. In the meantime, if anybody has any questions, please raise your hand or you can unmute yourself and say, Dr. Raghu, you have something?
No, just a couple of points which Dr. Radha very correctly raised, that evolution, you were used for generations to a particular type of oil, and that suits you, which it may not suit a person who migrates to a particular place because he doesn't have the evolutionary safeguards. Also, if you think about it, groundnut oil is very common in the West because amount of peanuts grown there is much higher. Sesame seed is very commonly grown in the South, and like she very rightly said, it's used in pickle preservation and all that. Similarly, mustard oil in the Far East and all that. I did a little bit of an experiment on myself. I sort of did my lipid studies, and I found that my triglycerides is usually in the range of 260 to 270. Then suddenly one fine day I found that my triglycerides had jumped to beyond 400. And then I started wondering where my diet had changed. So I decreased the oil and I changed other things, but it really didn't make much of a difference. Then I suddenly realized that off late I've developed a habit of drinking half a cup of Horlicks. This Horlicks is made with diluted milk and 2 to 3 teaspoons of heaped teaspoons of Horlicks powder. This is something that I've sort of grown to like from my childhood. So I started taking it warm cup of Horlicks in the night, and I cut my Horlicks completely. And 15 days later, rechecked my lipids, and my triglycerides had come down back to 62, 65. So, like Dr. Radha said, it's a composite thing, not just one aspect of oil is just one aspect of our diet. And how much can you change it to make a composite difference? Yes, it adds value to what is being done, all the healthy things, all the logical things that you do. But as a standalone, I don't think it is going to make a material difference. For example, if you cut down oil dramatically to say 2 teaspoons a day, and you bring a consumption down to a quarter of a liter per month, I don't think his chances of getting a coronary comes down so dramatically. If suppose the other factors are weighing in with their own risk factors. Thank you.
Perfect. Thank you so much, sir. We are at.
Really, I'd just like to add, just
Yes,
since Shastri raised the point, the prevalence of coronary artery disease in one study in vegetarians was 10.6. And would you believe it? This is 10.6 per thousand population. And would you believe it? In non-vegetarians, it's 11. And I don't know about, he raised a point about beef. Now, you know this much better. The incidence of beef eating in the Western world is far, far higher than what we have in our country. And yet the incidence of coronary artery disease is far lower than what we have. So I'm sure there are a lot of things apart from just oil or the kind of diet. It's your environmental makeup. It's your, like, for example, in one of the lectures recently, someone was took pains to point out that the lack of pollution in the last 4 months because of corona has brought down the incidence of coronary artery disease. So many things chip in and weigh in, and at best you can only suggest logical things to the patient and not be very categorical or very insistent about what you're saying is right.
perfect. Thank you so much, sir. And I'm again going to try to read some of the comments which are mentioned in the questions. So one of the question is, certain studies show that compared to coconut oil and olive oil, other oils have imbalance, can cause imbalance with increase in omega-6 versus omega-3, leading to chronic inflammation. So, this whole omega-3 versus omega-6, this argument is not well settled. The whole idea of omega-3 being protective and omega-6 being pro-inflammatory, that was originally thought of, and that is how this whole fish oil with the omega-3 triglyceride and everything that came up. But there is enough of counter data as well to say that omega-6 may not be that pro-inflammatory that people think. And they looked at the dietary patterns of historic times. You're talking about 2,000, 3,000 years ago in terms of what people were eating at that time. And they looked at the dietary consumption. And the ratio of omega-3 to omega-6 was anywhere from 1:4 to 4:1. So it's all over the place. Most of the plant-based diet, plant-based oil, they have higher omega-6 as compared to omega-3. And the general consensus is if you can balance somewhere between 1:2 versus 1:4 of ratio, that will be okay. To bring it down to 1:1 or anything lesser than 1:2, you will have to go to animal-based oil like fish oil and all this. So that is where that conundrum is, but that science is not yet very clear. So I did not give my thought. I typically do not base oil based upon omega-3 versus omega-6 content. Although if there is any oil which has got overwhelming majority of one of the two components, then rotation of oil is always better. But I certainly wouldn't discount one oil just because it has got higher omega-3 or omega-6. Then the question is US banned mustard oil because of erucic acid. I think that this we discussed about. Erucic acid had been shown way back in animal study. Canola oil does have erucic acid, but then Canada has pretty much taken over the production of canola oil with the genetic engineering, where now the claim is that the Canadian produced canola oil has got erucic acid of less than 2% content, to the degree of some production house even claiming there is zero erucic acid, although still being in the same class as mustard. So for canola oil to be sold in US, they have to pass that erucic acid content test, and that's how canola oil is available in US versus mustard is not in terms of edible oil. So that is how mustard oil still is banned versus canola oil is not. Sir, I'm still using olive oil. Is it okay, or shall I use 2 or more oils? So I think if anybody in India is using olive oil exclusively, I don't know how you are cooking, because olive oil has a very low smoking point. So if you are heating the olive oil to what you typically do for Indian cooking, that oil is of no use. So as Dr. Ravinder Reddy said, you use olive oil for light cooking or for salads, and then you use other oils like rice bran and canola or safflower for frying. Mustard and groundnut oil were popular in my childhood. Now I don't prefer them. Am I right? This has been very nicely brought out by Dr. Radha. I don't know what is right or wrong, but certainly your bringing up your ancestry seems to matter. So people probably who are born and brought up in the mustard belt, they probably consume mustard oil better as compared to people who are born and brought up in coconut belt, where they would consume coconut oil probably slightly better. So that is my answer to that. Should we look omega 3 to 6 ratio? I answered that question already. What is the relationship of virginity? I think that we answered already. So cold press oil. Uh, so I believe that cold press oil is better. This has been mentioned in by Dr. Radha as well. Cost is an issue, but more so even availability is an issue. Majority of the oil on the shelf are refined oil. Very few you will find which are cold press. Cold press essentially means you just squeeze the oil out without any processing. And because they don't go through high heating, you theoretically preserve all the nutrients or components or whatnot in there. So cold press oils are good, but they are costly. And again, their incremental benefit to the cost that they incur, that has not been studied. So we don't know as well. So that were all the questions and comments that I have read. Anybody has any other thoughts before we go with the closing comments? Any other questions for me, Dr. Radha or Dr. Ravinder Reddy? So the hard clinical data for oil is difficult to achieve, like what Dr. Shastri was saying, because it's difficult to randomize your lifestyle. You can randomize drugs, but you can't randomize lifestyle. And regional variation is difficult to compare because of the different genetic makeup and different gut microbiome, that you can't compare an Indian ethnicity with an American ethnicity with their change in oil pattern, because their individual ethnicities are going to dictate the cardiovascular outcome rather than the oil. So most of the data is derivative in nature. Most of the data is based upon the surrogate parameter, like coconut oil increases LDL, hence it is not good for heart. On the other hand, olive oil reduces LDL, so in a sense, it is protective for heart. So most of the data is derivative. Clinical heart point is very difficult to find. Dr. Shastri, you have something to add?
Yeah. Quickly, I just want, especially I see some of the residents here, they should go through the details of the Finland study. In early 50s and up to 60s, the coronary disease incidence and prevalence mortality is extremely high in Finland. They used to eat a lot of beef and non-vegetarian food. There is one person, a credit goes to one person, I forgot his name. He brought in changes from a governmental action. He brought in changes in the dietary habits, and it has remarkably reduced the morbidity mortality due to coronary disease in Finland. So when you are talking about these epidemiological and cohort studies, as I mentioned earlier, individual, we can't really be sure, but we should try, because we do not know which particular individual will get benefit, and an individual patient we can never demonstrate particular benefit with this kind of interventions. And actually it said, if you decrease the total LDL cholesterol of the population, or total salt consumption of the population, or total systolic blood pressure, mean systolic blood pressure of the population, that itself will demonstrate decrease in the morbidity mortality, even for pollution. If you decrease pollution, can you say that one particular person is benefited? No. So these are all, we have to accept them at a cohort level, but at the same time, we should not banish things and no, individually it doesn't work. And finally, when you're talking about the diet, I think Ravinder Reddy, I don't know whether he's still there. Last year, I shared with him one of the nice, simple scientific studies. When they looked at the gut microbiome before and after Christmas weekend, they demonstrated significant changes in the people who have gone to their in-laws' houses and who stayed back in their houses in US, because it's a significant change in the diet. So when we are talking about the oils and diet, especially diet and of course oils included, it is not necessary that they produce biochemical changes directly based on their saturated or unsaturated fatty acid content. They also change the microbiome, and microbiome in turn changes the inflammatory markers, and that may contribute to the progression or regression of the atherosclerosis and even onset. These are some of the thoughts. This is a big topic. We can talk endless without any conclusions. That's all, Anoop.
Thank you so much, sir. Dr. Ravinder Reddy, your closing comments in 1 minute, and then I'll go to Dr. Radha.
Okay, a few things. We heard talk saying that probably there is something good in beef. Now, the thing is, most of the vegetarians, we vegetarians eat only vegetarian junk. In other words, it's crap that is calorie rich and processed. So we need to have a very good combination. And that's why in Kerala, those who have, that doesn't mean that people in Kerala are eating only or having only coconut oil. They have a combination of everything else. And that is the reason why the incidence of other major is on par with the rest of the country. Now, coming to trans fatty acid, TFAs, trans fatty acids, the best way to tell your patient is to know about patient label reading. I mean, that's a very good thing. How we need to have a session on label reading. And any oil, they'll not say trans fatty acids. They say rich in hydrogenated vegetable oils. If this label is there, hydrogenated vegetable oils, then that they should not be taking that at all. So in my closing comments, it is not just the oils. Basically, you can divide that into 30% diet that includes the oils, adequate and a healthy diet, out of which 50% of your every meal plate should have only complex carbohydrates, either cooked, salted, or boiled or steamed. The other 30% comes from how active we are the whole day, that is physical activity. The other 30% comes from the fixed exercises. We do at least 150 minutes every week. And the last 10% comes down to the genes, on which we started off with the original patient. He's worried about those 10%. But if he takes care of this remaining 90%, then perhaps we can actually have a complete 100% reduction in the incidence of cardiovascular disease. And the other side of the coin is, of course, the drugs. But drugs are not the only thing. Thank you very much, Anoop.
Sir, Dr. Radha, your closing comment in 1 minute, please, for this session.
Actually, a
Dr. Radha, yeah.
diet does not just play with oil intake, but as I already completed or I already commented, that's an overall approach, a balanced approach to having inclusions of carbohydrates, protein, fats, and of course, the fruits and vegetables which add on to fiber. Fiber becomes a very, very important factor in our diet. So your whole grains add to fiber, and you take pulses, whole pulses, add to soluble or insoluble fiber. They have a role in processing fat. So all these are connected to fat that we take, and nothing works in the body without exercise. Something has to be done. We cannot just eat as less as calories as possible and say, I want to stay fit. It is not possible. However, less you take, you still put on or you are unhealthy unless and until you do some kind of exercise. And last, as Dr. Reddy said, genes do have a role, but provided the rest of the parameters are kept in control, that genes really are not a difficulty for us. Thank you.
So much, ma'am.
Can I add on one last sentence, Anoop?
Yes, sir. 30 seconds. We are very late. Yes, sir. Please go ahead.
Genes load the gun. Diet pulls the trigger. Thank you.
Thank you so much. Praneeth, your closing remarks, and then we are done after this.
Yeah. So extensive session. We discussed a lot. Definitely a bit of clarity on at least some step forwards in telling an advice when someone asks. So thank you all for those valuable suggestions and comments. It was a good session indeed.
Well, I think this is the longest session we had. We extended almost 20 minutes, but important topic and something that cardiologists are equally confused about. Thank you all for attending. Special thanks to Dr. Ravinder and Dr. Radha who joined us. And hopefully we'll see you in future session as well. Good night, guys.